It is time to Ask the Pros, the only live local interactive radio program that addresses home, health, and wealth matters Monday through Friday. A program hosted by arguably the most knowledgeable and reputable authorities in their respective industries, affording you the rare opportunity to ask them any questions related to their field of expertise for free. Just pick up the phone and call KAAM right now to Ask the Pro. Now, here's Dr. Birnbaum.
Good afternoon, everybody. It's Friday, the 5th of October, and we're just strolling along here. This is Cancer Update, a short walk through a long journey. If you want to call in, the phone number here is 972-445-0770. The toll-free number is 1-877-272-5226. I'd like to bring up something since we just got rid of our debate between the presidential candidates and talking about the Affordable Act. And we listened to both candidates. And I want to bring out something that is in, for clarity, I've got it here in the Hematology Oncology Today journal, talking about the components of the Affordable Act that Mr. Romney plans on including, and that is that insurers will not be able to deny coverage on pre-existing illness. Number two, insurers will not be able to drop a person's coverage because they become sick. Number three, there will be no lifetime limits on coverage, so coverage cannot be cut off even when it hits a threshold. Number four, children up to age 26, I believe in Mr. Romney's plan it's 25, will be covered by their parents' insurance. Number seven, for everyone trying to avoid future serious illness, free, I repeat, free preventive care is now covered. Now, that is one of the items that will be under discussion on some panel, and it's not that 15-man panel they were discussing. This is a panel that will decide what is considered screening that is beneficial and reaches optimum cost-benefit analysis, as opposed to just anybody who wants preventive care getting it for free. And the delivery of this high-quality care is critically important to the patients that are served, Americans at all ages with serious and complex illnesses. The new quality measures are adopted, new medical research funding will be allocated, and the delivery of these systems have to be calibrated to meet both patient and family needs. I think the big thing is the cost, the displacement of the $716 billion taken out of Medicare for what is called Obamacare. But these are some of the issues that they discussed the other day that need to be clarified so everybody has to distinguish, is able to distinguish between what is being offered by each candidate. If you have any questions, please call in. The number is 972-445-0770. With me today is my patient navigator, Miss Tina Withrow. Tina?
Good afternoon, everybody. I hope everybody's enjoying their Friday, and certainly the debates were a hot topic, and you bring up a really good point about what Mr. Romney has. I have a couple questions for you regarding that matter. If everybody is required to have insurance, so not everybody will, because we know that there are people that are going to skirt around that. But if everybody has to have insurance, that's going to drive down the people's visits to the emergency rooms, correct?
Hopefully.
So that will help in some way. That should help for you and I, because premiums should go down if there are more people buying it, one would hope. Am I right?
So far, you're right. I would agree with you.
And then if there's not a pre-existing, if you have somebody, let's say somebody feels a breast lump and they don't have insurance, potentially they could go out and buy insurance before they went to the doctor. I mean,
that's
correct.
That's correct. And hopefully there's going to be with this, with either plan, whether it be Romney's plan or with Obama's plan, it's going to create an atmosphere which I agree with, a competition. I think competition is always good in the market. Competition is good in that it helps people get better jobs, increase their salary, because 2 or 3 different companies may want the same person because of their qualifications, but it also will increase the ability to hire more individuals. By hiring more individuals, then you have increased tax revenues for the government.
And wellness is a big thing. And
without a doubt, wellness will cut the cost of medical visits to ER, medical visits to doctors, and the need for unnecessary workups on patients.
So we've got a lot going on in the way of health. Do you know what part of healthcare is part of our gross domestic product? Do you know what the percentage is of that? I don't.
I thought they said, I may be wrong, but I thought they said that healthcare accounts for 30% of the national budget.
Wow.
National expense for people. I just find that hard to believe in somebody. Let's just say you have a middle-class person whose business does $250,000, and let's say he's got 4 employees and he covers their benefits, after taxes. I can't believe that 30% of all their money goes to their health benefits. That just seems rather high to me.
I did read this week that an average premium for an employer group or an employer to cover just a family of 4, whatever it's like right around $15,000 a year.
That could be right. I know when we had the entire practice going at 3 locations, we had at one time 113 employees. I believe we were putting out close to about $214,000 a year for all of our employees to cover all their benefits.
Do you mean a month? Did you said a year?
I think that was the yearly. Maybe it was a month.
I think it was a month.
Yeah.
Because that sounds $20,000 a year. $2,000. No, that's not right. That would only be $20.
That's right. I think it was a month, around $200,000 to $216,000 a month to cover all the benefits for everybody. That was 113 employees.
Wow. So we've got to do some. I think we've got some hard knocks coming. I'm not exactly sure what they are, but screening. We talk about screening, and we put a lot into it, but some of it really isn't enough. I think that we need to give people more choices of where to put their dollars.
One of the things here, and they have various doctors who have commented on this. For example, Dr. Jed Gorlin, hematologist, addresses this, that physicians must play a larger role in containing costs in the way that improves outcomes as opposed to denying needed care. This means in the political process, you need to ensure the care and the quality are the foremost in an era of reduced resources. What concerns me goes back to the thing that we have talked about many times, and every one of these experts who have made comments in this editorial talks about, with this amount of new patients, with this amount of expansion of Medicare, Medicaid, with this amount of expansion of need for doctors going out into the community, is one, there's been a dramatic, in the last 5 years, there's been almost a 28% reduction in doctors going to medical school. Therefore, doctors going to internships, doctors going into family practice. And if you talk to the American College of Family Practitioners, you talk to those areas that deal with doctors, that deal with the average patient, not the subspecialists like cardiologists or pulmonary doctors or like myself, an oncologist. The everyday doctor, there's been almost a 40% decrease in available doctors out in the community. So my question is coming, and we're seeing more and more subspecialists that are having to take on dual roles, going back and doing their internal medicine in order to survive, in addition to their subspecialty, which could be pulmonary medicine or nephrology and kidneys, or neurology for nerve doctor, or oncology for cancer. There just are not enough doctors out in the community. And on top of that, they've talked about, both candidates from both parties have mentioned, and nobody has really emphasized it, they kind of bypass it because it's going to scare the entire community. And that is a reduction anywhere from 14 to 18% in Medicare and Medicaid reimbursement. So now you've got a surplus of patients where you were seeing maybe 5 or 6 Medicare patients a week. Now you're going to be required to see as many as 20 a week. And the reduction in reimbursement.
You mean 20 additional?
Additional, yes, 20 additional. And the reduction in reimbursement, where are you going to find the doctors? And it's easier in the metropolitan communities like Dallas and North Dallas and Collin County. But where are you going to find them in Prosper? Where are you going to find them in Princeton? Where are you going to find them in some of your outlying communities? Who is going to be willing to go out there and service an additional 20 patients a week and have a 20% reduction in reimbursement? I mean, I think this is where they're kidding themselves. You cannot force the doctor to take on more patients. And you and I both have seen how many doctors do we see are not taking Aetna, for example, because Aetna has cut their reimbursements. I've talked to cardiologists. Doing cardiac stents has dropped like 40%. You're getting more and more private insurance, much less Medicare and Medicaid. And you and I see how many patients that come to us that have Molina or Superior or Medicaid because nobody else will see them. And then I get a new Molina patient. We had one today. And I said, I need to write a letter to your family doctor. Who's your family doctor? He said, I don't have one. And I said, what do you mean you don't have one? He says, well, nobody will take my insurance. So we have to pull out our list of doctors, or I'm going to have to be set up to take care of these patients from an internal medicine point of view.
And from a preventive standpoint, if somebody doesn't have a family doctor, how much is that costing when the patient really isn't taking care of their health? You're handling them from the blood issues or the crisis. I mean, because you really, as a specialist, you're a crisis manager, really. You're a crisis physician.
You're right. In my types of subspecialty, people who come to see me are in a very crisis, serious situation. And the sad thing about this is that pretty soon, and I don't know what the state laws are regarding emergency rooms, but I think it's going to get to the point where a lot of patients are starting to use the emergency room as their primary doctor.
Oh, it's that way now.
That they are going to get turned down.
I tell patients right now the best time to go to the emergency room is about Sunday morning, about 10:30, because everybody's still in church. And, you know, it's kind of the joke. Everybody says, hurry up and get to the emergency room before the Baptists get out of church. It's kind of, you know, funny, but it isn't, because, you know, they're being overrun. I have a daughter-in-law who's a nurse in the emergency room. My son is a tech in the emergency room. You know, they get overrun. Look at the expansions of the emergency rooms. Everybody's expanding their emergency rooms. So there's a reason for it. And really, aren't the emergency rooms a pretty good breed for getting sick?
Well, there's a lot of studies that say that there's an increased incidence of infectious disease, not only in hospitals, but principally in emergency rooms. I mean, I've got another article right here, Infection Prevention Management of Critical Care for Cancer Patients because of the high risk of complications. This is a article that has been put out. Let's see, who is this one by? By Dr. Jorge Parada from Harvard, professor of medicine, medical director of infectious disease, at Loyola University in Illinois. And he is talking about the enormous amount, almost a 40% increase in patients who become neutropenic, meaning you give them chemotherapy or you give them high-dose radiation and their blood counts drop. And a lot of these patients are not symptomatic, yet they have very low white count, which puts them in a phase of neutropenic sepsis. And they should be put on prophylactic antibiotics for them coming down with a full blood-borne infection. and you're looking at enormous cost here. So who's going to treat these? Does the oncologist treat them? Does the infectious disease doctor treat them? Do they go back to the emergency room, or does their family doctor treat them? So it's just an ongoing vicious cycle, and especially in hematology oncology, when you're dealing with such highly dangerous and caustic drugs like chemotherapy and radiation therapy. The cost is prohibitive after a while, that you're going to have to take the chance that you're not going to be able to treat these patients. Then you're just in a horrible tailspin. They go into neutropenic sepsis. They have to be put in the hospital. They have to be put in isolation. And all of these just increase the cost of medicine on a daily basis.
And that's what it is. It all just comes down to the cost. The cost versus benefit ratio, I guess, is what we're really talking about. Will you be glad? I was on the phone today with an insurance company who pre-existed somebody, and so you've been treating this individual, and unfortunately she hadn't had insurance because she's completely pre-existing. Everything is pre-existing. So I think that's one thing that both the Romney and the Obamacare are going to include is the elimination of pre-existing illness. And there's some fine-tuning to do with that, but I think that's one that's very important, because you have, in the past, people that have had colon cancer gone into complete remission. They're in 5-year complete remission. They go in, they get their routine yearly chest x-ray. There's a mass found in their chest. They get a biopsy. It says compatible with colon cancer. And they say, oh, yeah, 5 years ago I had colon cancer. So in the past, they had a pre-existing illness, and they couldn't be covered. It would have been better had this person come up with lung cancer, a new disease, than a pre-existing previous disease. Now, hopefully, with the institution of who's ever planned, call it Romney Care or Obamacare, they both incorporate the use of pre-existing illness to eliminate it. And I think that will help drive costs down. I think it's pretty interesting, though, that I wonder how they figure in the cost of the electronic health record, because I still don't believe that the electronic health record is saving money, because people still want I still want hard copies. As I look at a computer screen every day, I still want to print it because I may want to read it later, and I would be the same way on my medical health record.
Well, obviously you're talking to the wrong person here, because I'm a computer idiot. When I go to the hospitals, I call before I get there and ask them to print up everything, because I like to be able to write on the report and check off things and keep a copy for my office. And a lot of times it happened yesterday at a hospital in McKinney. The computer froze. Not only could we not get the main screen, but it wouldn't scroll up or down because it was frozen. So they say, well, we'll have it ready in an hour. What am I going to do? Sit around there for an hour waiting for the computer to work?
When your patients are waiting for you to get there to see them.
I prefer the old method of you get a paper copy that's always put on the chart. You have the time to review it, sit down. A lot of times the patients want to see it. They want to see their lab when I go into the hospital room.
Maybe this is a conspiracy by the printers, the inkjet printers who want to make money. Who knows? Question for you. This is off of oncology, but I don't know if you saw this on the news, but did you see or hear about people who were getting back injections? Now they find that they have meningitis.
Steroid. We were just talking about it today.
Can you clarify?
I don't know how it came about. We were talking to the representatives with the pharmacy that we use, American Specialty Pharmacy, which I think the public should be aware of this pharmacy. They do oral oncolytics. They do routine prescriptions. They do chemotherapy. They do antibiotics. It's an excellent pharmacy. They're located in Plano. It's called American Specialty Pharmacy. Let me see if I've got the phone number here. And we were talking about this because it was brought to my attention that this was in Texas. This was a compounding pharmacy, not a CVS or a Walgreens. It was a compounding pharmacy.
That's right.
That put together these prescriptions. It was a steroid prescription that is used in injections with Marcaine for pain management. I had one of these on my back because I have collapsed vertebrae. About 2.5, 3 years ago, a combination of a steroid and Marcaine for pain management. And
is that a Facet injection, or is that what they call a Facet injection?
That's right, a disc injection. The American Specialty Pharmacy's phone number it's located on 2709 West 15th Street, Plano, Texas, is 972-867-4204. They're an excellent pharmacy, and they give free delivery to your house. So if your doctor who you have wants to write you a prescription, they can contact the American Specialty Pharmacy. They do everything from compounding to special concoctions to oral oncolytics to routine hypertensive cardiac prescriptions, antibiotics. And their phone number is 972-867-4204. But this was a compounding pharmacy here in the state of Texas. And I do not know, nor do I want to profess I know, somehow the steroid component was contaminated. And I understand, what was it on the news today? 5 people have already died from the meningitis, and another 12 are infected. So I don't know how it became contaminated, but anytime you're going to be introducing a needle into the spinal cord, it's not like doing it in the arm where it just simmers and proliferates. This is death-defying. It gets right into the spinal fluid and goes right to the brain. So that was frightening to hear that.
Yeah, it just real. But from a physician's standpoint, if you were an orthopedist who were doing this, you would have no control over it. I mean, you get your things through a clearinghouse in sterile form, or what you assume is sterile form. So it's not like you have any control over that. Am I right?
You're right.
So you do it, and then,
your office orders up who their supplier is, and unfortunately, and God forbid, you don't find out till later on that you had the bad lot. If you remember, what was it, 3-4 years ago, we had in our office heparinized syringes that were contaminated, and we used those heparinized syringes to flush our Mediports and flush our PICC lines, and it was us. It was Presbyterian. Presbyterian Hospital in Chicago? Denver Presbyterian, and 2 other hospitals outside the state all had the same lot from the same supplier, and we were one of them. We had the CDC in our office for about 10 days, 2 weeks. That was just devastating. I mean, they shut down everything because they want to make sure nothing else was contaminated. So you are relying on your supplier. Now, I don't know how many people, we do it now, but in the past, a lot of people will check, where did this come from? They'll get a box of heparinized syringes, prefixed syringes, and they want to know, where did you get this from? Did it come from New York? Did it come from China? Where did they come from? And I really mean it can't come from China. It can come from someplace in Europe, because the majority of all your drug companies are in Europe. So you don't know where these pre-mixed syringes come from all the time. They come from your supplier. And the syringes are safer.
They're safer that way, correct?
I was about to say yes, but I think I would, in something like this, in a prepared syringe, I'd almost trust my own nurse getting an individual bottle of heparin and drawing up the heparin themselves than having it shipped to me as already pre-mixed heparin that comes to me, because at least I know my people are drawing it up and it's done correctly. However, that's really not the issue. It's the quantity and the drawing it up. The issue is that the actual heparin in the vial that was used to make the pre-fixed prepared syringes was the contaminant.
Well, and then when this happened to you, I have to say you were the only. Because I remember reading the letter from the Centers for Disease Control thanking you, because this had been going on for some time. You
were their
reported
test case.
You were their test case, but there were other places, if I understand correctly, that had this and knew they had it and never reported it to the Centers for Disease Control.
That's right. That's
so
right.
they thanked you for being forthcoming and saying, "Hey, we got a problem. We need help." And
I'll be quite honest. I was more petrified because it never happened to me before. And you're looking at people just plain shutting down your office, and you got no recourse.
And if I understand correctly, this was syringes from Mexico that you came.
I honestly don't remember.
I think I remember
you're
that.
right. I think they came out of Mexico or out of Canada, but it was a lot. And then you could see you have some reputable hospitals around the country that were using the same syringes, not because they were cheaper, it's just they were available.
Well, and really, gosh, how often do we look at things these days and you turn it over and you say, it's either from two places. It's either from China or it's from Mexico. So,
That's
right.
right.
It's not like you can track it and say, okay, I'm calling China right now and making sure that everything in my office is, you just assume if it's packaged and it's airtight and, you haven't had any problems before, you just assume that it's a sterile environment. So the other part of it is, as bad as this particular situation is, if you stack that up against all the thousands and thousands of people who get facet injections.
Oh yeah, not only that, the benefit far outweighs the toxicities, but
unless it's your mother,
that does not solve the problem of the 5 people who died.
Yeah,
there's you got to be concerned about that, because if it can happen to those 5, it can happen to somebody else. So that's one of the main things. Another article that came out here that I think we talked about over a week ago. This is from the ASCO annual meeting. ASCO is the American Society for Clinical Oncology, held in Chicago June the 1st to the 5th, that shows the addition of Avastin to chemotherapy doubled the disease-free interval amongst women with platinum-resistant ovarian cancer. Now, what does that mean? That means one of the mainstays of patients who come down, women who come down with ovarian cancer, and this is an article out of the professor at the University of Paris and head of the investigation group of the European continent on Etude Cancer Ovaire, meaning the large cancer group, which did trials of over 25,000 metastatic ovarian cancer patients, that showed by adding Avastin to those patients who had failed Platinol, which is the mainstay of ovarian cancer, improved their disease-free survival by well over 50%. So this is just an ongoing trial that shows that while we sit here every day and talk about things going on, it's important to you cancer patients that you become aware that things are going on as we talk in order to improve the survival. The other article that came out here was on the maintenance therapy improves patient-free survival, even though it has increased toxicity. Those metastatic breast cancer patients, we've always talked about when is enough is enough. When do you stop giving chemotherapy? When do you stop and just watch the patients? They showed that those patients who were put on maintenance chemotherapy for metastatic breast cancer with a combination of gemcitabine, which is Gemzar plus paclitaxel or Taxol, had a longer patient-free survival, even though they had slight increased toxicity because of the administration of the drugs Gemzar and Taxol. And this increased disease-free survival in these patients showed an increase in 18 months versus 8.3 months without using it. So that's an increase, and even though toxicity was increased by 41%, survival was increased by 33.3%, which is quite significant in order to have a strategy that will maintain response rate in people who are putting on maintenance therapy for breast cancer. I think these are things that we like to bring up to everybody. And the last thing that I'll bring up here, the last two things, I think we talked about this about 3-4 weeks ago, but there's a recent article on the American Academy of Cancer Research, and there are many diabetics out there. And they have shown that the using of the diabetic drug metformin has an increased potential cancer therapy effect in those patients with coexistent pancreatic cancer who have diabetes. The research showed that 117 patients treated with metformin had a 2-year survival increase of 30.1% as compared with those patients without metformin who had a 15.4% survival rate.
So it doubled their survival.
Just about. And now they're starting to use this drug metformin. This is done by Dr. Dong-Hoo Lee, professor of gastroenterology at MD Anderson Hospital, who is a co-author. The anti-tumor effects of metformin translate into clinical benefit in the form of improved response to chemotherapy and prolonged survival. So those patients out there that have biliary tract cancer, cholangiocarcinoma, gallbladder cancer, or pancreatic cancer need to discuss with their doctor if they're going to an oncologist just that. What do you know about the use of metformin in my disease, and should we try it?
When we come back from our break, I want to ask you a question related to that, Dr. Birnbaum, and the question will be, should you take it prophylactically? We're going to go to break right now and come back
and join us.
Rosalind Slaughter is a very busy wife, mother, and teacher. She didn't have time for cancer.
After my first diagnosis, I had 2 lumpectomies, but the cancer had already spread. The doctor gave me little hope for recovery. That's when I called Texas Hematology Oncology for a second opinion. It had become stage 4 breast cancer.
The physicians and staff at Texas Hematology Oncology Centers aggressively attacked her cancer and were concerned about her quality of life during her treatment. Rosalind has been cancer-free for over 8 years now.
It really makes a difference who you choose for cancer treatment.
Rosalind and others have turned to the cancer treatment offered by Texas Hematology Oncology Centers. Perhaps you should too. Texas Hematology Oncology Centers has offices that are located in Dallas, Carrollton, and McKinney. To call for an appointment, please call 469-453-5500. That's 469-453-5500. Welcome back, everybody. You are listening to Cancer Update, a short walk through a long journey. We're going to go ahead and take a call, and then I have a question for you, Dr. B. Good afternoon. Welcome to Cancer Update.
Hello there, both of you.
Hi.
Hello.
And, I try to listen to you every Friday whenever I'm around, and I listen to this program regularly, and you got the best program out of all 5 days, and thank you for doing what you do on this show.
Thank you so much. That's really nice to hear.
And this particular program is so good because there are not many people out there talking about the problems with the upcoming Medicare thing, and particularly with the lack of doctors that are going to be able to cover it, like you pointed out.
You know, it's funny that you say that. Tell me your name.
I'm John in Plano.
Hi, John in Plano. It's very interesting. We tend to assume everybody's talking about what's happening with the election and Medicare in their homes, and they're talking around coffee in the morning. But I had something happen this week. I had a patient that I had navigated for a very long time, and they came by to see me and give me hugs and kisses, which I'm really tickled that they did. But we started talking about it. And they had no idea that this was even happening. And they're highly intelligent people. They just hadn't been listening to that because they really didn't think it was going to affect them. And I think sometimes we turn a blind eye because we just assume, oh, that's not really going to affect me, but it's going to affect everybody across the board. Young, middle-aged, older people, and we've got to talk about it because, that could be a real problem for our country if we don't really get on the ball.
Let me add something else here. I really think, and I don't know how many listeners we have to this program, probably more than Fox News. We're much more popular than O'Reilly
Thousands.
and Hannity, probably in the millions. But having said that, and knowing that this is the Mork and Mindy show, my question to everybody sitting out in the community is, whichever plan is passed, you need to go ask your doctor. Really, I mean, I'm real serious about this. Let's say your doctor is Dr. Tom Jones, which was a great Albert Finney movie. And just ask him, Doctor, are you going to take Medicare? Or are you thinking about dropping Medicare? Are you thinking about dropping Medicaid? They may not even be taking Medicaid right now. But I think that's something really important for everybody out in the listening audience to ask their doctor, because they better be prepared. Because sooner or later, the doctor is going to notify you that as of December the 1st or as of January the 1st, I will no longer be seeing Medicare doctors. And if he's gracious enough, he will say, here's a list of doctors who will be seeing Medicare patients. And unfortunately, let me just tell you this. A lot of these doctors, like our practice, is one of the few, if not the only, oncology group that is willing to see Molina and Superior. We have patients that have to come to us in far west Tarrant County, all the way up to the Oklahoma border, south as far as Cleburne, who are on Molina that have no doctor because doctors in their area quit seeing Molina, especially in oncology. We have very few oncology groups here in the Metroplex that will see Molina, will not see Superior, will not see Medicaid. I've just always felt it was my duty to do that, not for any heroic reason, just to do it. But with the new Affordable Act plan, I think everybody out in the community ought to take the time and ask their doctors, if you are a Medicare patient, Dr. Jones, if this goes into effect, are you going to continue to see Medicare? Which then, let's just say hypothetically 50%, and they're estimating it's going to be higher than that. But let's just say 50% in the Texas area, in the Dallas-Fort Worth Metroplex, stop seeing Medicare. Well, who are they going to go see? And that brings up the question that we discussed earlier. That's going to put a tremendous burden on certain doctors who are going to have to increase their practice by at least 20 new patients a week. And at the same time, the plans are to cut Medicare reimbursement to physicians by anywhere from 14 to 18%. So these are questions you need to ask yourself of your doctors. What position are they going to be taking? Because you may need to start looking now, because as we all get older, we're going to come down with more serious illnesses, and I hope you have a doctor take care of you.
John, let me ask you, what concerns you most for you individually? Just if you could let the listening audience know, what concerns you most about what's happening?
Thank you for asking that question, because I had a bigger question that I wanted to ask you guys, but Dr. Beerbaum just said that topic as good as I could say it, because I think it's a huge problem. Everybody's talking about insurance, but if we got no doctors that are going to see patients, what good is the insurance? But here's the bigger thing, and he just talked about metformin. And it's the number one diabetes drug out there.
Probably so. One of the top, that and glibocide. You're
right. In
right.
terms of sales, I think it's number one, but whatever. But here's the issue, and this concerns anybody listening, whether they're 5 years old or 95 years old. And nobody knows this, and therefore nobody's talking about it. Maybe you guys occasionally, which is, almost all prescription drugs deplete key nutrients in the body. Now, metformin, for example, do you know what the key nutrient that's depleted by metformin is?
No, I really don't.
B12. Do you know what the symptoms of low B12 are in the body?
Yes, but I understand where you're going with this.
Nerve problems, tingling in the fingers and the legs. And if it's prolonged B12, because if you're diabetic, you're going to be on it forever. And so if you have prolonged B12...
Well, to give you a little history on this, John, because we're going to need to get going, B12 deficiency causes Addison's disease, which is what John F. Kennedy had.
It also causes Alzheimer's.
Yeah, there's a lot of things that it can cause. We're going to go back. John, thank you so much for calling.
Thank you for your program.
Okay, question that I had for you, Dr. B. So metformin, we talked about metformin. So it increases people with pancreatic...
Well, what it's done, they show that in using metformin, there is no statistical evidence that metformin in and of itself, not as of yet, they're still doing the research, improves with chemotherapy the response rate and disease-free survival in patients with biliary tract, mostly pancreatic cancer.
So my question to you is, no
different. Let me add one other thing. No different than aspirin. They have shown, and we've got an article here today that talks about the use of aspirin, not only in the prevention of thromboembolic disease and the prevention of blood clots, but also they've shown that aspirin has been effective not only while you're on chemotherapy in some aspects for colon cancer, but it improves the response in people who have colonic polyps and preventing them, therefore preventing the pre-existing condition of colon cancer.
So you're getting my point that I'm trying to get at is, should a bunch of us be talking to our doctors about going on metformin as a preventive measure?
Well, you're talking to somebody that truly believes in prophylactic treatment, especially in the neutropenic patient or the possibility of neutropenia induced by chemotherapy. I put my patients on, as did my mentor at MD Anderson. He put people prophylactically on antibiotics so they would not come down with infection. I don't see any literature out there that says that you should be put on prophylactic or preventative metformin because with every drug, as the gentleman just said, there is a side effect with that drug. It's going to prohibit absorption of certain items, and the last thing you want as a normal person is to take metformin and drop your blood sugar and go into hypoglycemic shock. So, no, I would not advocate the prophylactic use of metformin. But
or going and getting diabetes so your doctor can put you on metformin.
I think you and I were going to talk about this in the meeting of Hematology Oncology in July 2012. The article came out that shows in colon rectal cancer there is an enormous prevalence, higher amongst African Americans versus Hispanics versus white individuals, that could explain the difference in tumor burden between the two groups. What I found most interesting about this, and I cannot pronounce the doctor's last name, but it is Ashtorab, associate professor at the Department of Medicine at Howard University Cancer Center in Washington, D.C., and it's further collaborated by the American Society of Clinical Oncology. Based on their data, African Americans are at a 3 to 4 times greater risk than other groups in the United States, as most of them, and this is what was the most interesting thing about this, as most of them are diagnosed with the colorectal disease earlier in life, and at the time that they're diagnosed with metastatic disease. So, as opposed, most of the colorectals I see, obviously, are metastatic. Patients send them to me when they become metastatic. A lot of the colorectals, probably 35 to 40% of them, start out as an early stage colon cancer, stage A or stage B, and they are cured with surgery alone. What this article is saying in the African American population, which is the highest, the next highest is the Hispanic, and the lowest is the white population, is that not only is there a higher prevalence of colorectal cancer in the African American population, but those that get it start off in a more advanced disease than other people that start off with colorectal cancer. And they are recommending that in the African American population, there should be an earlier onset of doing colonoscopies. There should be an earlier onset of screening and checking as you do in the African-American population, have the highest incidence of coronary artery disease, of hypertension, and now it's showing that those who have the incidence, prevalence of developing colorectal cancer, not only is their incidence higher, their prevalence is higher, but those who get it start off with a more advanced form of the disease already having spread in a metastatic environment. So again, it's talking about the need for early detection and certain populations that have shown to have a higher prevalence for developing a certain type of cancer.
Well, let me ask you this, because, we talk about colon cancer and it's such a devastating disease. Why haven't we worked harder to reduce the cost of a colonoscopy? And why is that not cost? Why are the insurance companies not taking up a lot of that cost? Because I think really in some of those numbers that you just talked about, I think we're talking about the fact that people aren't doing it because it just, who has $1,500 and a day off of work to have your colon checked? I mean, it becomes a matter of economics for some of these people. I know it has been for me. So, I think we need to change how we do it. I think we need to have the gastroenterologist, honestly, have the surgery centers, have they been drastically cut?
Well, there are two ways of looking at this. And, I worked under one of the best gastroenterologists when I was at MD Anderson. That was melanoma and GI tumors was my main interest. You go through all departments, but those were the two that I had my biggest interest in. And I worked under the late Dr. Robert Nelson. And I learned how to do colonoscopies. I was very proficient at it. And when I came into private practice, I realized you got guys out there that are gastroenterologists that do their own colonoscopies. And if you want to build up a business, a referral business, you don't go stepping on everybody's toes. So that's point number one. Then you start using these other doctors to do your colonoscopies and upper GI endoscopies. They have taken a hit, as have the cardiologists, as have the pulmonary doctor who put a tube down to do a fiber optic bronchoscopy. They have taken hits from $3,000 down to $2,000, down to $1,100, down to $600 for doing procedures. So how much more they can take a hit, I don't know.
Okay. All
right. And then on top of that, if they're taking Medicare, the Medicare reimbursement as opposed to private insurance is probably 25 to 32%, even lower. So, they had to do extra years of training at their own expense, and they take time out of their day. What is a fair price? I mean, I'm not one to say that. I'm not one that believes in that. So that's the first issue. The second issue is I do not believe, because of the cost, and not only the cost to the doctor, but the cost to every hospital has their GI lab. So you've got to have an associate. You got to have a endoscopy nurse, an associate there to help out the doctor. So it's almost prohibitive to do it for free. I don't know any place will do it for free. I don't know. I've never heard of anybody doing, quote, screening colonoscopies.
Let me ask you this. iPads and Apple, right?
Yeah.
That's the latest and greatest. You have one. I have one. I have an iPad. I wonder how Apple would feel if you bump it up just like in the healthcare. I wonder how they would feel about having their profits reduced like we have in the medical field. It wouldn't happen, would it?
No, not at all. But, this is totally outside the realm of what we're talking about. It's something what they talked about the other day. You lower the cost, you got to lower the regulations. There's so many regulations out there that that hurt you from doing procedures as there is in going into business. If you cut back on some of the regulations, then you're able to lower the tax burden. If you lower the tax burden, then you're able to lower the costs.
I did a whole program one time with one of the drug companies, and it was entitled "The Cost of Medicine," and they compared that, what the pharmaceutical companies do up against Westinghouse or GE. It was a pretty interesting thing. I've had a request from Mary who wants to know an update on Dr. Modi. So I want to give you Dr. Modi's office number. Her number is 972-734-8844. I want to tell you Dr. Modi is a geriatrics physician. She's one of the few that we have found. She does house calls. I like that. I think that's very interesting. But she also has offices in Carrollton and in Dallas at the Dallas Medical Center location. Correct, Dr. B?
Correct.
And so, Mary, thanks
Absolutely, just a phenomenal, pleasant lady who is very patient-oriented. She answers her own cell phone. She believes in answering the cell phone for her patients. I kind of think calling her a geriatric doctor is a disservice to her. Yes, she sees a lot of older patients and even nursing home patients, but she is a highly qualified, board-certified internist who sees patients really of all ages, and she is extremely knowledgeable in hematology and even in oncology. And what I like about her, and I'm not, I don't even think I've gotten a referral from her, but we sent her quite a few patients, is that she's very conscientious and she knows when to use a subspecialist. She doesn't go beyond her bounds. If she has a cardiac problem, she'll send it to a cardiologist. If she has a GI problem, she knows when to send it to a GI doctor. But I think what's most important about Dr. Sina Modi is that she is extremely compassionate, phenomenal bedside manner, and she's available. And let me tell you something. In today's medicine, that is so much more important than if the doctor is a buddy with your doctor, because very few doctors answer their own cell phones or even give out their cell phone number.
Well, I like sending patients to her. I get good responses back. Again, let me give you her number. First, I want to give you the RHD office number, our number. If you have questions for Dr. Birnbaum, you can call 469-453-5500. And then I would also like to give you Dr. Modi's office. Her number is 972-734-8844, and she is accepting new patients. Let's see. Anything else that we want to talk about, Dr. Birnbaum? We've got about 5 minutes left on the show.
Well, one of the things, we've got a patient right now who's undergoing treatment for rectal cancer, and he is on a protocol of chemotherapy with the radiation therapy. His radiation therapy is being delivered by Dr. Jerry Barker at Presbyterian Dallas Hospital. Jerry is a just phenomenally superb radiation oncologist. I'll never forget when I was in training at MD Anderson, there was this guy at 12 o'clock at night that was jogging by my house every night. And it was Jerry with his son strapped onto his back. And Jerry was the late Gilbert Fletcher, the father of American radiation oncology's protege. Brilliant doctor. And Jerry is now head over at Presby Dallas, and that little strapper on his back is the head at Moncrief Radiation Center, Jerry Jr., which is kind of comical. But Dr.
You're
Barker,
dating yourself.
I know. Dr. Barker is a superb radiation oncologist at Presbyterian Dallas. He's treating our patient. And this patient is on a regimen of Folfox, which is 5-FU and oxaliplatinum. And now there is an article that just came out in Clinical Oncology Alert that talks about the use of capecitabine, which is Xeloda, an oral agent very similar to 5-FU. Rather than giving IV 5-FU, it shows that Xeloda is better than and not inferior to 5-FU IV in perioperative treatment of rectal cancer. Why do I bring that up? Because this is an oral oncolytic, an oral agent. And more treatments are going towards oral agents, like in non-small cell lung cancer, Tarceva. There are more and more oral agents, like in renal cell cancer, Sutent. So I want people to be aware that the devastating effects of IV therapy have not gone away, but there are so many new drugs available out there that are oral agents that not only are as good as, but improve survival in various forms of cancer, be it breast cancer, colon cancer, or kidney cancer.
I think that's really, really good. I think we've got about a couple minutes left. And I want to say, how long have we been doing this show, Dr. B, together?
I don't know, 15 months?
15 months, couple years. And it's been a real delight for me. I have really enjoyed being part of this radio show. I've enjoyed what I do in patient navigation. But I will be no longer part of the radio show here.
Yeah, one more Friday to go?
Yeah. And that's still to talk about. If I'll be, I may call in next week. I'm not sure, but I certainly have enjoyed it. I am moving on, and I am no longer going to be patient navigator for Texas Hematology Oncology. I'm very proud of the work that I have done there. I've always said we've done great and magical things, and we have. When I posted on my Facebook, thank you all for all the sweet, wonderful comments that you had, and I so appreciate that. But watch me fly, and that's what I've said. So thank you so much for this format. I have a real passion for cancer survivors. I love you all, and I hope that you will continue to listen to this show and continue to check in with Dr. Birnbaum for Cancer Update. And it has been my real joy and my real honor to be part of your Friday afternoons. So thank you very much. Again, this is Cancer Update, a short walk through a long journey. Thank you, everybody. Have a very good weekend. Bye now.
Go Rangers.
It must have been cold there in my shadow to never have sunlight on your face.
You've been listening to Ask the Pros, heard every Monday to Friday right here on 770 KAAM. Should you wish to speak with any of our experts, please call KAAM at 972-445-1700 and we will connect you with them immediately. Thank you for listening to Ask the Pros.